Clinical chemistry. Cardiac markers. Suppose you are given a patient in an examination with chest pain, an electrocardiogram, and a table showing cardiac marker results at different time intervals. How do you interpret the findings and arrive at the correct diagnosis? That is exactly what we'll cover in this lesson. By the end of this lesson, you should be able to identify the major cardiac markers, interpret serial laboratory results, explain why repeated troponin measurements are important, understand the release pattern of different markers after myocardial injury, and confidently answer examination-style questions. Let's begin with a clinical case. A 60-year-old man with a history of hypertension and long-term cigarette smoking arrives at the emergency department after experiencing about 3 hours of severe crushing chest pain that radiates to his left arm. His electrocardiogram demonstrates ST segment elevation in the inferior leads. You are also provided with serial laboratory results for several cardiac markers measured at admission 6 hours later and 12 hours later. As you examine the table on your screen, notice that the troponin concentration increases significantly over time. Creatine kinase MB also shows a rise before beginning to decline later, while myoglobin rises very early and then falls rapidly. These changing patterns are extremely important because they help determine both the diagnosis and the approximate timing of myocardial injury. Now let's answer the questions step by step. The first question asks for the diagnosis with reasons. The most likely diagnosis is an acute inferior ST segment elevation myocardial infarction, commonly called an inferior STEMI. Why is this the correct diagnosis? First, the patient has classic symptoms of myocardial ischemia. The pain is central, crushing in nature, and radiates to the left arm. Second, the electrocardiogram demonstrates ST segment elevation in the inferior leads, indicating injury to the inferior wall of the heart. Third, and perhaps most importantly from a clinical chemistry perspective, the serial troponin values show a clear rise over time. Rather than remaining stable, the concentration changes dynamically, indicating acute myocardial injury. When characteristic symptoms, compatible electrocardiogram findings, and a rising or falling cardiac tone occur together, they satisfy the diagnostic criteria for acute myocardial infarction. The next question asks why serial troponin measurements are necessary. A single troponin measurement is often insufficient. Imagine a patient presenting very soon after the onset of chest pain. At that stage, troponin may still be within the normal range because not enough time has passed for it to enter the bloodstream. On the other hand, some patients have chronically elevated troponin levels due to conditions such as chronic kidney disease or chronic heart failure. If only one measurement is available, it becomes difficult to determine whether the elevation represents a new heart attack or a long-standing abnormality. That is why serial measurements are essential. A rising or falling pattern indicates acute myocardial injury, whereas a stable elevation is more likely to represent chronic disease. The next question concerns the release kinetics of cardiac markers. This simply means understanding the order in which different markers appear and disappear after myocardial injury. Begin with myoglobin. Myoglobin is the earliest marker to rise. It usually becomes elevated within 1 to 2 hours after myocardial injury. However, it lacks cardiac specificity because it is also found in skeletal muscle. Therefore, although it rises quickly, it is not considered the best marker for diagnosing myocardial infarction. Next is creatine kinase MB. Creatine kinase MB generally begins to rise within about 3 to 6 hours. It reaches its peak after approximately 1 day and usually returns to normal within 2 to 3 days. Because it returns to normal relatively quickly, it is particularly useful when clinicians suspect a second myocardial infarction occurring shortly after the first. Now consider cardiac troponins. Troponin also begins to rise within approximately 3 to 6 hours but reaches its highest concentration later. Unlike creatine kinase MB, troponin remains elevated for several days, making it the most sensitive and specific biochemical marker of myocardial infarction and the preferred laboratory test in modern clinical practice. Finally, there is aspartate aminotransferase, or AST. AST was once used as a cardiac marker, but today it has very limited clinical value because it is found in many other tissues, including the liver and skeletal muscle. It is therefore considered a nonspecific marker. Now pause for a moment and test your understanding. Suppose you are given another patient with typical crushing chest pain. The electrocardiogram demonstrates ST segment elevation, but the initial troponin level is within the reference range. Would you immediately exclude myocardial infarction? Pause the video and think about your answer before continuing. The correct answer is no. A normal troponin measured very early after symptom onset does not exclude myocardial infarction. The patient may not yet have released enough troponin into the circulation. The correct approach is to repeat the measurement after the recommended interval and look for a significant rise or fall. Let's move on to another important examination question. Can you list the biochemical markers of myocardial injury? Pause the video if you would like to answer before we continue. The principal markers are cardiac troponin 1 and cardiac troponin T, which are the preferred markers in current clinical practice. Other markers include creatine kinase MB and myoglobin. Historically, AST and lactate dehydrogenase were also used, although they are now largely of historical interest. For patients with suspected heart failure rather than myocardial infarction, brain natriuretic peptide and N-terminal pro-brain natriuretic peptide are important laboratory markers. An ideal cardiac marker should have several characteristics. It should have high sensitivity so that even small myocardial injuries can be detected. It should have high cardiac specificity so that elevations accurately reflect heart muscle damage rather than injury to other tissues. It should be released early after myocardial injury. It should remain elevated long enough to allow diagnosis. The laboratory assay should also be rapid, reliable, reproducible, and affordable. Finally, marker concentrations should provide useful prognostic information. Now consider another examination question. What conditions other than acute myocardial infarction can cause elevated troponin? Pause the video and try naming as many as you can. Troponin can increase in several non-ischemic cardiac conditions, including myocarditis, heart failure, rapid arrhythmias, cardiac trauma, and following cardioversion. It can also increase in situations where oxygen demand exceeds supply, such as severe sepsis, profound anemia, or hypertensive emergencies. Several non-cardiac conditions can also produce elevated troponin levels. Examples include pulmonary embolism, chronic kidney disease, stroke, subarachnoid hemorrhage, and prolonged strenuous exercise. Finally, laboratory interference, including heterophile antibodies, may occasionally produce falsely elevated results. Next, let's discuss natriuretic peptides. Brain natriuretic peptide, commonly called BNP, and N-terminal pro-brain natriuretic peptide are released from the ventricles when the heart muscle experiences increased stretching due to pressure or volume overload. Their primary role is the diagnosis and assessment of heart failure. One of their greatest strengths is that a normal result makes heart failure very unlikely in a patient presenting with breathlessness. Higher concentrations generally indicate more severe disease and are associated with a poorer prognosis. These markers are also useful for monitoring response to treatment. Remember that concentrations tend to increase with advancing age and reduced kidney function, while obesity may produce lower than expected levels. Finally, let's discuss high-sensitivity troponin assays. Modern high-sensitivity assays can detect extremely small amounts of cardiac troponin with excellent precision. This allows clinicians to diagnose myocardial infarction much earlier than older laboratory methods. However, increased sensitivity also means that more patients with conditions other than myocardial infarction will have detectable troponin concentrations. For this reason, clinicians should never interpret an elevated troponin result in isolation. Instead, diagnosis depends on combining the patient's symptoms, electrocardiogram findings, and, most importantly, the dynamic rise or fall seen on serial measurements. To summarize today's lesson, remember these key points. Troponin is the preferred biochemical marker for diagnosing myocardial infarction. Serial troponin measurements are more valuable than a single measurement because they demonstrate the rise and fall that characterizes acute myocardial injury. Myoglobin rises first but lacks specificity. Creatine kinase MB is useful for detecting reinfarction because it returns to normal relatively quickly. BNP and N-terminal pro-brain natriuretic peptide are primarily markers of heart failure rather than myocardial infarction. Finally, always interpret laboratory markers together with the clinical presentation and electrocardiogram findings because no laboratory result should ever be interpreted in isolation.